And now, Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Hello, I'm Dr. Paul Conley, and welcome to another episode of Doc Talk. Today we're going to talk a little bit about diabetes and how it affects Americans here in this country. When we talk about diabetes in America, there's 34.2 million Americans that have diabetes, and that's approximately 1 in 10 Americans. The other thing is about 1 in 3 Americans have actually pre-diabetes, and that's about 88 million Americans that are pre-diabetic. One of the concerns that we're going to talk about today is how we're having an increase in our youth. So in this country, over the past few years, we've been seeing more diabetes in our young individuals. Tonight, our special guest who's going to talk to us and kind of guide us through diabetes is Dr. Charles Burdette. So Dr. Burdette, thanks for coming back on the show.
Thank you, Dr. Conley. Thanks for having me.
I really appreciate you coming on the show. You know, we're talking, a little bit earlier at the break, how you're our very first guest on vaccines, flu vaccines, pneumonia vaccines, and of course, that still is very, very important. That people get their vaccines, and also you've been on here on our show with Men's Health. But I thought it was really important, when we talk about just health in general, especially in the country and in West Virginia, that we talk a little bit about diabetes because it's amazing that we've had like 88 million Americans out there with pre-diabetes. That's 1 in 3, and I think one of the things that I was a little concerned looking at some of the numbers is the fact that we're seeing increased risk of our youth, our children, with not so much type 1 diabetes we think about in children, but actually type 2. So I guess my first question to you is exactly what does it mean when someone has diabetes? What is diabetes?
Well, diabetes, there's actually 2 types of diabetes. Many people, of course, have heard, and as you well know, about the 2 types, but we'll go through it and just give a brief introduction. Type 2 is the one that most everyone knows. That's where you take metformin. This is usually what they used to call the old age diabetes, the diabetes that people would get at older age. This is where the body just doesn't use its insulin appropriately. It becomes resistant, and your sugar levels go up. Type 1, which, as we talked before, Dr. Conley, my son is a type 1 diabetic. That is where the pancreas becomes attacked by an autoimmune disorder, and they produce no insulin at all. And these children are usually, that can happen anywhere from birth, anywhere even up into young adulthood, type 1 diabetes can show up.
Yeah, I've actually, speaking of type 1, I've actually seen patients, even older than that to have, type 1, and maybe they just kind of flew on the radar until they finally burned up enough of their beta cells, these insulin-producing cells, and then they, obviously, really declare themselves that they're type 1.
Absolutely.
So again, I talked a little bit about the prevalence of diabetes. Maybe you can, kind of go back and talk about, obviously, I think, we all know of someone maybe in the family or someone you maybe go to church with that suffers from diabetes. So maybe you can just talk a little bit about what is diabetes, how do we diagnose that, and what does that mean, and what is pre-diabetes, and what exactly is that?
Right. Thank you. Those are excellent points. Well, diabetes, it actually just means actually water. That's the actual term for it. But the diabetes mellitus means the sugar. Okay. How you, I guess you were asking about how we diagnose diabetes. Usually people will show up with different kind of symptoms. Mostly they will show up with not feeling well. Sometimes they will be talking about the fact that they urinate a lot, that they need to drink a lot, very thirsty. Sometimes they'll be losing weight, and they'll come in to get checked. And sometimes we will find that on a test, we'll find their blood sugars are anywhere above. Right now the diagnosis is 100 to 120 on a fasting glucose. If it's above that, we usually run what's called the A1C, the hemoglobin A1C. And what that is a percentage of our hemoglobin that's been affected by high sugar. And numbers above 5.7 to 6.4 are considered the pre-diabetes, as you were mentioning earlier. 6.4 and above is basically diabetes, and that's how we diagnose diabetes.
So who's at risk? When we're talking about, diabetes and we diagnose. I mean, so folks, watching the show here, Dr. Burdette, who would be someone, watching this program, would be someone that may be considered at risk? Is there a certain ethnicity, certain race, creed? Tell me a little bit about that.
Yes, sir. Basically, the big risk factors are really for all ethnicities is people who are overweight to develop diabetes. If they have any pre-diabetes, as we discussed, if they're having those levels of the A1Cs that we discussed, if they have family history, they have a brother, sister, parents who've had that. Also, we talked on the radio about physical activity. Folks who are very sedentary, who don't exercise more, at least 3 times a week, are at a higher incidence. And also, ladies who have had gestational diabetes are also at high risk. Ethnicities, really, unfortunately, we found a higher elevation in our Asian Americans, African Americans, and also our Indians or the Native Americans.
So it's something that you talk about, with even our women. I know sometimes that's how they're diagnosed. I guess they're pregnant and then they do. Do they still do glucose tolerance tests anymore, Dr. Burdette?
Yes, they do.
And so maybe you can tell us a little bit about like what is a glucose tolerance test and how that might actually identify someone at risk for diabetes.
Absolutely. A glucose tolerance test is where actually you drink a very sugary drink, and we monitor your blood sugars over time, usually within the first 30 minutes, hour, 2 hours, and basically look at what those levels are. If your body is operating appropriately, if you are not resistant to your insulin, the insulin will bring these sugar levels down and keep them within that 100 to 150 numbers that we were talking about. Unfortunately, if they're not on some of the glucose tolerance tests, when you're seeing numbers 200 and above, that puts you, that basically signals for us as physicians to do further testing to determine if the A1C is elevated.
Yeah, I want to kind of go back, my OBGYN days. I know that there's a certain number of basically if you have a lady who's fails her glucose tolerance test or has gestational diabetes, they have a significantly increased risk that they will in their lifetime develop diabetes. Is that correct?
That's correct. The incidence is somewhere in the 20 to 25% range. The numbers actually are on a National Diabetes Statistic Report. It's available from the CDC. It's an excellent resource. It's something that I had reviewed for this discussion tonight.
So, maybe you can clarify a little bit, again about the difference in type 1 and type 2, because I think, so type 2, correct me if I'm wrong, it's not an insulin production problem. It's more of our body's, I guess, inability, let's say, to use the insulin. It's like insulin resistance. Is that a word or something that we think about with type 2?
Yeah, that's correct, Dr. Conley. Type 2 diabetes is insulin resistance, and that is where that the body cannot use the insulin appropriately. Our cells become resistant to that. We see that a lot, unfortunately, in folks who are obese, and because of the fact as you get larger and larger, unfortunately, there's more body that has to be treated with the insulin. So there's more that has to be produced, and unfortunately, the body downregulates its use of that insulin, and unfortunately, you start to have higher and higher blood sugars, which can then lead to other problems in the body over time.
So I guess some of the risk factors again for diabetes, some of the things like with type 1. So again, the type 1 again is the individual who again basically it can be someone who's healthy, otherwise healthy. They're just not producing enough insulin. So is that something that you see mainly genetically? Is that something that more runs in families? Maybe you can tell me a little bit more about the difference between type 1 and the type 2.
Absolutely. Type 1, of course, is very genetic. It is seen a lot in families. There's usually, they'll have brothers, sisters, uncles who have had grandparents who have had type 1 diabetes at some point. So that is something that is you'll see it a lot with brothers and sisters that will happen. And really at any age you can have type 1 diabetes, but again it is typically called the juvenile, and it's usually seen up through early adulthood. However, our type 2 diabetics, as you were alluding to earlier, unfortunately can end up on insulins as well because of the way the body reacts to their natural insulins, but it reacts better to the insulins that are given as a medicine.
You know, it's you know, for what I do in GI world, gastrointestinal world, you know, it's interesting that, you know, things such as like celiac disease or that's a gluten allergy, definitely people that have celiac or gluten have a marked increased risk of type 1. And so, you know, if someone has type 1 diabetes, we now usually screen for gluten sensitivity because we know that that in itself is an autoimmune type of process that can do that. You know, before the break, I guess I want to kind of go over again, just if you can, you know, for the audience again, people watching the show, what would be some symptoms again that someone, you know, may have that they want to consider, you know, seeing a doctor and getting, you know, some blood work?
Absolutely. First thing is what we call polyuria. That's urinating all the time, having to go continuously. And you actually pee a relatively large amount. You also have, if you have to drink a lot because you're thirsty all the time, if you're hungry all the time, if you're losing weight without trying, blurry vision, some of those are things that you should seek care.
So, you know, I was thinking too about diabetics and healing, wounds and things like that. So is that something else that if someone has, you know, a wound or something that doesn't heal as well, feeling tired, there's some symptoms or signs of diabetes as well?
Those are signs as well. They should definitely go to their physician and get checked.
So I guess, you know, when we talk about, you know, screening, when, Dr. Burdette, should one be screened? I mean, at what age should someone come in and see their doctor and get, you know, either a glucose check or a basic metabolic panel? What are the guidelines as far as like when someone should consider seeing a doctor and just getting their sugar checked?
Sugar checks right now, the recommendations at age 45. However, if you've had a parent or a sister or brother who's had it, you should get checked about 10 years after they developed it. So if they were 45 when they developed it, you should start coming in at 35 to get those checks.
And obviously, I assume, you know, that if you have some of the symptoms that you're talking about, that increased thirst, increased urination, you know, the blurry vision, or sores, you know, heal slowly. I mean, obviously, I would assume that if you have anything like that, that you would want to be checked, you know, prior to that age, right? Absolutely.
Yes, any of those signs, you should, no matter what age you are, you should come in and get checked. Yes, absolutely.
Well, it looks like we're getting ready to come up against a break here. So what I'd like to do, if it's okay with you, Dr. Bett, we're going to take a little quick break. And when we come back, I'm going to have you talk to us a little bit about how we do diet modification, some of the medications that are out there, and maybe you can talk about what we call comorbidities that are associated with diabetes, because we know diabetes itself is a systemic disease and it can cause a multitude of other health issues as well.
Absolutely.
So we're going to take a little commercial break. We'll turn back in a few minutes and we'll come back to Doc Talk.
At Plateau Medical Center, we have the newest technology, which is robotic surgery. Prior to us getting it, you would have to travel out of the area into a larger hospital. Using the robot, less pain, quicker recovery time, quicker return to normal activities, and shorter hospital stays.
This new robotic platform allows us to do what we do and do it even better, and that's only going to benefit our patients.
It's not about the technology, it's not about the robot, it's about patient outcomes.
And now, Doc Talk, brought to you by Plateau Medical Center. Here's Dr. Paul Conley.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and tonight we have our guest, Dr. Charles Burdette, and we're talking about diabetes. And so before the break, we talked a little bit about how we basically diagnose someone with diabetes. We talked a little bit about what diabetes means and what numbers, you know, basically would qualify someone with diabetes. So I guess, you know, now that we have a person who we diagnose them as having diabetes, I think, you know, the big question is how do we manage that how is diabetes treated? I know we got diet modification, we got medications out there. So maybe you can kind of just navigate through basically how you as a practitioner or family physician would manage that patient with diabetes.
Yes, sir. Well, type 1 diabetics, we'll go through that very quickly at the beginning because most of our treatments and most of the concerns are really about type 2 because that is the much larger and much more specific disease process that we have, particularly here in West Virginia. Type 1 diabetics need to be testing 3 to 4 times a day because they need to do their insulin injections. And that's primarily how that is treated. Type 2 diabetes, the major thing to do is diet changes, and that is minimizing those sugars and carbohydrates. My patients are going to, if they see this, they'll hear this speech. I tell it almost every day, probably 2 to 3 times a day. They need to avoid their sugary drinks. That's your pop, your sweet teas, your energy drinks, and your sports drinks. Almost all those are very high in sugar, okay? So that means that McDonald's sweet tea, I always tell them, take the top off and let it dry and see how much sugar is actually in that sweet tea. It's scary, okay? Second thing is your cookies, cakes, candies, pies, ice creams, your snack foods. Those are a big thing. Have to minimize those down to basically nothing if you can, or just occasionally, okay? And then the big one is your carbohydrates. That's your breads, potatoes, pastas, corn, and rice. And basically anything with flour, so pastas and breads, biscuits, your crusts, your pizzas, all those are very high in carbohydrates. Your potatoes in any form. They always hate it when I say that, in any form. You also have to watch your pastas in any form, and the corn and the rice. So, corn chips, cornbread, those are things to watch from the diet standpoint. Then also, of course, exercise, being as active as you can, getting out at least 3 times a week and trying to get anywhere from 5 to 30 minutes of exercise. Most of your exercise folks will tell you, even starting with just 1 minute a day and then increasing over time, like 2 minutes a day, then 3, then 5, and before you know it, you're up to 20 minutes a day. Those are big things. So those are really the first 2 big things that folks can do to both prevent diabetes, and as well as they think they have it before and don't want to go get checked, they can at least start doing those things to help themselves.
Yeah, I think it's sneaky, with the sugary drinks. I think a lot of times we don't realize, and I think that's one of the things when we talk about the pediatric population and the youth is, just how many, calories and how much sugar you get in those, whether it be Kool-Aid or like you said or the iced tea, and I think people don't quite realize how many calories they're getting. And it's always something that my patients don't quite understand is how can a baked potato really increase my sugar elevation or pasta, whether it be like macaroni and cheese or any, like I said, or spaghetti and bread, and I think that they have, somewhat of a hard time quite understanding how that gets broken down from a complex, carbohydrate to a simple sugar. I think we all pretty much know, eating a candy bar, what that's going to do. But I think, folks don't quite, understand that. When you talk about, type 1, again, type 1, that's the person who, pretty much they have to be on insulin. Orals are not going to help them. They have to be on insulin because they're just not making insulin. But, the type 2s, they have plenty of insulin. In fact, they have excess insulin. It's more of a resistance. But a lot of that's due to weight. Is that correct? It's like
that's
basically,
correct.
So it's like the person who's obese and they have what we call insulin resistance. So weight loss, I know at the break we were talking a little bit about, weight loss, and I know with that there's different ways, that an individual can lose weight. Can you talk to us a little bit about how one should go about, weight loss?
Absolutely. Well, obviously the diet modifications that we just mentioned are the number one thing. Reducing those sugars and carbohydrates, and as you mentioned, reducing their calorie intake is a big thing. And then increasing their exercise as they can. The big issue is for us, particularly here in the United States and West Virginia, is the portions of our foods. How large meals are now versus 50 or 60 years ago. When you think about, I can remember as a young child, eating at a fast food restaurant, and the meals that my parents had were the kids' meals today. What we call kids' meals today was what the adults were eating then. So the portions have just gotten so much larger. So again, working on that, the exercise, any kind of exercise, actually walking would be the best thing for most people to do, just walking around their yard, walking down the street, walking around their neighborhood. And, unfortunately with this COVID situation, they can do that and wave and talk to folks from a distance. At least get out and see their neighborhood and not feel trapped in their home, which would also help with two things.
So, when you talk about weight loss, I know we were talking about, diet is very, very important. Exercise is very important. But I guess, if you have individuals that they're doing diet, they're losing weight, they're exercising, and they're still having difficulties with that. What about medications? And maybe you can guide us a little bit about, if you turn on the TV, you see there's certain medications you can take by mouth, and then there's certain medications that are injections, and then of course you're talking about insulin. Maybe you can help us a little bit about what medications are out there and how one would start if someone were to need to go on medication.
Well, the oral medications, and that is an excellent point, Dr. Conley. Metformin is our number one medication. It is the one that most people are on. If it can be tolerated, which some people can't tolerate, and that's why there are five other classes. Pardon me. There's about 6 oral medication classes out there. Without getting too technical, but metformin is the number one that people use, and usually they add in something like a glipizide that people have heard about. There's also neuromedicines out like Januvia and Farxiga, and then there's several medications within those classes. There are some other ones out that used to be used like Actos, which has been pulled from the market. That class has kind of fallen down and not being used except in very specific situations. So there's 5 or 6 different oral options, but most doctors will tell you we usually go to 2 or maybe 3 orals, and then at that point we have to start thinking about the other medications.
So as far as like some of these oral medications, I guess they work in different ways. You're talking about metformin. Maybe you can explain a little bit about how does metformin work versus you mentioned the Januvias and how do they work, and how can you use those in combinations like with the glipizide, and maybe you can just talk a bit about how they work on the body and how they're effective.
Metformin particularly works to do really 2 things. One is to block the production of the sugar that you mentioned earlier, Dr. Conley, from the liver, so that it's a little bit better controlled. Slows it down. It also has a mild effect of slowing down absorption of glucose within the intestines, within the gut, so that you do not absorb as much of the sugar. Now, that doesn't mean that you can go out and eat everything you want while taking metformin, but it does protect you in that way. The Farxiga is one that you see a lot of. That is one that actually helps to push your sugar through the urine. It actually helps to open up, if you will, it opens up valves in the kidneys and allows the sugar to go through the urine. Januvia actually helps to kind of stimulate the pancreas to produce a little bit more, as well as it also works on in the cells themselves to help uptake the sugar a little better, as well as the insulin a little better.
And then, of course, I guess the glipizide is the sulfonylurea, glucotrol, glipizide, Amaryl. I mean, those are some brand names. They actually stimulate the pancreas.
They actually stimulate the pancreas. Thank you. I forgot to mention those. That they help to stimulate the pancreas to produce more insulin as a way to try to help bring that sugar down. Unfortunately, in type 2, because the body is resistant, those sometimes have to be used in combination with other drugs. They're really not the first line medication.
So, but some of these medicines, I think it's interesting. Like you're talking about the medications that help to where you urinate sugar. So tell me a little bit about. They have some other benefits as well, right? I mean, as far as like blood pressure and some other things and weight loss. Is that right? Because you're actually urinating or excreting sugar in the urine, right?
That's correct. They do have a small weight loss, about 2 to 5% 5% of weight loss, pardon me, 2 to 5 pounds of weight loss can be done with those medications. They also do lower the blood pressure, and a couple of them are being looked at. They're doing studies to see if there's protective mechanisms for the heart.
So we got orals out there, and it seems like there's several different orals that people can kind of look at. The metformin and how it works. Then we have the sulfonylureas that stimulate insulin production. And then we got ways that actually excrete sugar through the urine. So there's different mechanisms there. What about some of these? People ask me about these injectables. Some of these are like now they're once a week. Victoza was like once a day injection, which I always thought that was interesting. I mean, the initial one, I guess, Byetta, was actually derived from, I guess, Gila monster, saliva is how they originally found that. Okay,
yes.
And found that it actually worked on glucagon. So maybe you can explain a little bit about combination with the injectables and how do they actually work?
Well, the injectables, the ones you're bringing up they all fit in one class called GLP-1. That's a particular hormone in our body that actually works on multiple systems in the body to help reduce the sugar, also to try to help minimize the effects of sugar and diabetes on the body. Victoza, as you brought up, and Byetta were the first two. Victoza was daily. They now have weekly ones. Ozempic, you'll see that commercial all the time. Byetta, Bydureon. And these work very well, and they're a good step that once you get to 2 or 3 orals and you're not really helping, it's once a week. You can inject it once a week, and it's before you have to take that next step to other medications.
And then I guess finally you talk about insulin. So when in your mind or practice should we use insulin therapy?
Insulins, the recommendations at this point from the American Diabetes Association, from the Endocrinology Associations, are when patients have A1Cs above 9. When they're staying above 9 consistently, that insulins really are the best medication to bring that down. Our target is to have people with A1Cs below 7. So when they're above 9, you need to have that down. And in the insulins, as you were bringing up, we actually have 2. We have the rapid acting that everyone's kind of familiar with. That's the 3 or 4 times a day medications. But there's also the long acting insulins, which are the basal insulins you take once a day.
So it seems like there's several different options out here as far as the different types of insulin. You got rapid acting, you got the short acting, and then some of the orals. I guess when we talk about with insulin and with some of these pills that are out there, how often should one check their sugar? How do we monitor how effective it is? We talked about this hemoglobin A1C, which is like a 3-month average, but how often do you recommend someone check their sugars?
Most everyone should be checking their sugars once a day as type 2 diabetics. Type 2 diabetics should start at once a day, and sometimes, unfortunately, if the sugars are not really controlled, if the A1Cs are high, sometimes we will have to get no permission, shall we say, or allow them to test 2 or 3 times a day. But sometimes you have to work with our insurance companies to get those approved. But at least once a day and religiously. People should be doing that every day and watch how their numbers do, because that testing not only tells us how they're doing, but also tells them what foods they should avoid.
Well, I think it's important too, if they test, then they can actually make a diary and a log, and in that way I think it gives them a little better way to track and trend their sugars. Well, we're going to take one last break, and then we're going to come back and we're going to wrap things up here with Dr. Burdette, and we're going to finish things up with diabetes.
Plateau Medical Group welcomes Dr. Yancey Short to the Plateau Health Network. Dr. Short, a board-certified general surgeon, performs minimally invasive, laparoscopic, robotic-assisted, and traditional surgery. His care ranges from hernia repair, screening colonoscopy, vasectomy, and skin lesion removal. Dr. Short sees patients at 2 convenient locations: West Maple Avenue in Fayetteville and George Street in Beckley. Call our office today or request an appointment online at plateaugeneralsurgery.com.
Here's Dr. Paul Conley.
I'm Dr. Paul Conley, and thank you for returning back to Doc Talk. So we got Dr. Burdette here, and we're going to wrap things up with diabetes. We've been talking about diabetes, and again, if you can, just summarize for us, a little bit about the prevalence of diabetes in the country, and finally, maybe you can talk about, we know it's a systemic disease, and you can talk to us a little bit about what are some of the comorbidities or some of the other organ systems that are affected by diabetes.
Absolutely. Well, as you mentioned earlier, Dr. Conley, 34 million people, 10.5% of the U.S. population, has diabetes, actual diabetes. They estimate another 20% are undiagnosed. 88 million people have pre-diabetes, so that's 34%. So we're talking over a fourth, or a third of the U.S. population has some level of sugar issues. And unfortunately, diabetes and high glucoses can affect many things. The eyes are one of the first things. Blindness can come from long-term untreated diabetes. The blurry vision is because of the sugar in the eyes themselves. Cardiac disease, heart disease. Diabetes increases your risk by over 25% of increasing having cardiac disease. Vascular disease, the issues with folks who have bad circulation, they lose toes, feet, legs because of diabetes. Kidney disease. Kidney disease is growing and growing, and part of that is because of diabetes. It can lead to requiring dialysis for diabetes. Also, the peripheral neuropathies, the neuropathies that people can have where you can start to lose the ability to write, to hold on to things. Also, the feelings in the feet, the burning, the stinging. You see that a lot on the commercials. So diabetes is not just a sugar issue. It is really a whole body issue. It also increases your risk for strokes because of the vascular disease. So it is a body-wide issue. There's also GI problems, as you know, with gastroparesis, so you can actually have slowing of the gut. So it can affect your body from head to toe.
Yeah, and also in the GI world, when we think about, fatty liver disease, it's, 2/3 of our diabetics have fatty liver disease. It's
Yes.
now the #2 cause of liver transplant in this country, and probably in the next 5 years, fatty liver will be the #1. And again, we think about diabetics, and so I think dialysis, #1 cause of diabetes. So I think diabetes is so important, and it's more than just checking your sugar. It's more than just a number, on a glucometer. It's basically a systemic event that we see. So I really appreciate you, Dr. Burdette. Again, you've been a wealth of information. Going over this with us, talking about how we can kind of navigate with the disorder. The diet, the exercise. And again, as far as like the comorbidities, and I know there are certain websites, that one can go to. Do you know of such a thing?
Well, the diabetes.org is the American Diabetes Association. That's my most recommended site for folks to look for information, but also WebMD is a good place as well.
Well, again, Dr. Burdette, I appreciate you for coming on Doc Talk again. For those who are watching the program, I appreciate your attendance, and until next time, good night.